Hello, welcome. I'm Matthew Goodwin at WashU in St. Louis, and I'm joined here by two of my colleagues.
I'm Dan Sciubba from Northwell Health in New York, and I'm a neurosurgeon.
My name is Larry Lo. I'm from Northwell Health as well, and I'm also a neurosurgeon.
Thanks for joining me. Both these guys are friends, colleagues, and also mentors that I trained under. And so I feel like we're just going back in time where I get to pick your brain again. The topic today is deformity in spinal oncology. And I can say I love this topic because when I started as an attending, I feel like I paid a lot of attention. I feel like I didn't pay enough attention to it, even though I was trying to. You know, and I had some that I had to go back and correct. And I had Mike Kelly as a partner who helped me with a lot of that. And the amount I learned was tremendous through that. But I learned that it's a big deal. And so I guess we can just start by, talking about, maybe we can each have you weigh in on your thoughts in general on deformity in tumor patients, right? Because I remember when I started training, and you might go over a case, and this is early on in residency, and somebody might say, degen case. Don't make a degen case a deformity case. Right. Just stop with all the numbers and the PI and the balance.
Right.
And now we know that you probably should be thinking about that.
Right.
You get flatbacks and you get problems. You go up a level, more problems unless you correct it. And so, how do you think about it in tumor patients? I think both of you probably consider those things.
Right.
But how much do you consider them? And what are your thoughts on them?
Right. Really, I have to credit Dan in teaching me this, but I do think that it's been a paradigm shift in terms of actually thinking about oncological cases as deformity case. Just like you can make an argument that any type of spinal fusion is basically a deformity case, right? You're either creating a deformity or fixing a deformity, right? I think that for oncological cases, if we're not taking those into account, we definitely create problems. And even if we hit a home run with the local control, from the cancer perspective, we are creating long-term problems in terms of disability, reoperations. And I would say that until fairly recently, at least in my practice, I wasn't getting a standing film on the oncological patients, but now I am to try to account for that. And it's something that Dan taught me.
Yeah, I would add that we spend so much time, and I think I'll speak on behalf of at least the three of us. I think we all like to geek out with this stuff. I mean, we really find it interesting. We always think, at least I do, that my surgery is not perfect in some way and there's something new to learn next time. If we go all the way to the extreme in cancer, it's local control, neurologic preservation, and in the long-term survivors, fusion. Not as much of the alignment has been until more recently we focus on it. If you go into the deformity, you can go really deep looking at the C2 tilt on a patient who has a 1-level TLIF. And you're sitting there saying, what's their global balance? How do I match their Rusli type? How do I recreate them? And all of a sudden you take a degen TLIF and you say, maybe we need to go very long because they have multiple problems and really need to address it. When those two come, and I'm happy to explore either one. When those two come together, I still think at this current time, we are still sacrificing something for another. Right. To think that I'm gonna have an 80-year-old who's not age-based alignment, meaning that we have to make her perfect to her Rusli type, and she's got a primary tumor, or she's got a metastatic tumor and might be on chemo.
Right.
Now you're really stretching to get everything done. So I think what's gonna happen is we're gonna keep looking at our patient outcomes and saying, and I really do think it has to be empiric, because the strategy, we should care about everything, but what's happening is if you do a 3-column osteotomy at L4 when a patient presents with a T3 burst fracture from cancer, and you say, well, I'm gonna fix this, but while you're here, I'm gonna make you taller, it's probably too much. On the other hand, if you don't take a standing film, you're missing so much, and you're not thinking about it. And if you're not trying to look at the measurements, you're probably not being thoughtful about this patient long term. So I think, again, we have these multiple, sometimes attention issues, where if you're a deformity surgeon, you're saying, I'm gonna make them perfect for as long as possible. And if you're a cancer surgeon, I'm just gonna get them through the night. That's probably both are wrong,
right? And
they have to kind of be met in the middle.
Yeah, I like how you said that. So one of my favorite patients had a primary tumor. I resected it, fused her down to L4 or 5, and made her too flat, lower down. She was leaning forward, young, female, normal, got a good margin. She was doing great, except for she was, looked terrible when she'd come in. I hated watching her walk down the hall. And the thing was, she was, like many tumor patients, so resilient. so resilient. More, she wanted to do more PT. You know, I have a series of 9 months of watching this because I'd say, you know, I think I made you too flat. We should fix it. And she go, oh, why don't we do a little more PT? You know, why not try to get a little more?
Right.
And eventually we fixed her, and it was a big fix. And she was like, oh my gosh, this is just so different.
Right.
But it's remarkable to remember how debilitating, especially if you're a tumor surgeon, how debilitating deformity is. I mean, it's such a debilitating thing that when you give it to someone, even in this really young, robust, resilient person in their 20s, it's really debilitating.
Absolutely.
The one I struggle with now, that was a long lead in into this, is the metastatic patient.
Right.
Who, kind of like you said, they, you know, maybe they have a terrible deformity and they have metastatic disease, and you're kind of going, well, they probably need an operation, whether it's cord compression or instability. Where do I stop? How do I do this operation without having them fail above or below it, and without going crazy and doing something that's too big, that's too much for them?
Right. I think in my practice, for the sort of the elective metastatic cancer population, where they're coming in with sort of a radiographic finding of cord compression, and because of how tight the cord compression is, they can't get SBRT as the treatment. And these patients, I feel like overall have more limited systemic disease, and they're coming into your office with a good performance score.
Yep.
For those patients, I'm definitely getting a standing X-ray, and whatever operation that we're planning is taking that into account. Now, I'm probably not crossing the thoracolumbar junction or doing a 3-column osteotomy just to kind of get them to their age-based optimal alignment, but whatever is sort of within the levels of the intended operation, I'll try to do my best to try to straighten them out if they're kyphotic or whatnot. I think it's a little bit tougher in the non-elective situation where you've got a patient that's non-ambulatory where we can't get those standing films.
Right.
And I think that for those patients, generally speaking, I do the deformity side of things. There's sort of obviously we try, if they're focally kyphotic from a burst fracture causing hemiplegia, we'll fix that, but it's sort of a little bit harder to try to best realign them when they don't even have a standing film to begin with.
Right.
Yeah, I would just add something, and I know you guys both know this, at least about my style, which is I'm extremely transparent, for better or for worse. You know, I'm always very blunt. I think that communication goes a long way. I have a patient who I saw who's a physician, and he had undiagnosed lymphoma, but it was causing severe spinal cord compression from a burst in the thoracic, and then he had a cauda equina in a lumbar. It was basically this guy who was super tough and dealing with pain and hunching over at those fractures. And so he had an upper thoracic, we did a corpectomy and fixed it, and then we did a lumbar, which was L2 to the pelvis, and the guy did great. And he's since developed a new lesion in the middle that wasn't fused, and then that was treated well, but that kind of shrunk away with some of the treatments that they had, and now that's formed a compression fracture. So I see him and he goes, everything's holding up, the screws are holding up, the tumor is at bay, and I'm looking at the images going, are you happy? And he says, I'm very happy. So I think I did the same thing you did, and I'm not as yet the point where we've gone and connected the dots, but I said, you've had surgery. This will be another surgery to make you stand upright. And I think the cancer patients are a little different, and it depends on where they are in their stage. If a deformity patient's saying, I'm looking at my life, and maybe they define it by their work or their home or their age, the cancer patients are thinking about their life from day to day. I mean, literally every time they get a new blood test or new study, they have an emotional reaction, and it's either a honeymoon or it's a nightmare. And so I feel like in those situations, you just have to keep communicating them, saying, I think this is important to you, and if you keep doing well, you might really want to fix this and make you as straight as possible. If they sit there and every time you see them, they look sicker, it would be, I think, wrong of me to make them go through a surgery that might impact their life in a negative way when they have a limited time. So I guess the whole point of that story was, I keep communicating to this person my thoughts, but he has to then communicate to me where his heart is and where his health is. And that's why I say some of those constraints get a little narrowed, because you can't just say, let's make it look perfect, because you don't have the timing. Communication matters.
I think every year I learned to listen more. I had a renal cell with bone was eaten away in the front, looked terrible. I told him he needed either back, front, back, and he couldn't ambulate, couldn't do anything. Facets in the back were busted, and they couldn't embolize it. because they had a feeding artery coming out of there. They tried. And so we went in the back first and just stabilized them, thinking we were coming back in the front. And kind of to your point, the guy was like, that's enough. Like, I feel so much better. I'm stable. I can transfer. I can stand, get to the walker. Wow. And he discharged and was fine for several months more. But, he had late stage disease. And,
right.
and it kind of makes you realize that our goals oftentimes, and what we look at and go, ooh, boy, that's not going to work. There's nothing in the front. Sometimes for them, it's perfect. It's exactly what they need. And usually they're telling us that.
And just to add to that point, I think that's a great example. I would still say, as you're doing that case, you're still trying to make those rods harmonious, what you think the alignment should be, as opposed to, okay, you don't want the whole thing? Well, then I'm just going to do the smallest, simplest thing here, and then it doesn't look right for him. So even in those 6 months, you can't predict that, 6 months or 12 months or longer, you want his alignment to be as good as possible. And so I think that's where the sweet spot is we're trying to incorporate those deformity principles. And like we said, the deformity surgeons are having a problem with this because they're sitting there going, am I doing a C2 to the pelvis on the 75-year-old who's got multiple areas of sagittal decompensation? Even that for a patient who doesn't have cancer is maybe too much.
Right.
So I think we have to rein that in and communicate both with the patient and for anyone who sees a lot of cancer patients, or actually the people who don't see a lot of cancer patients, need to talk to the other doctors.
So how have you managed to do such a good job staying in both worlds, deformity and tumor? I mean, because you're dare I say, you're known in both worlds. You converse very well in both worlds. You're kind of with both the people. Most of us aren't like that. I had a partner, and I kind of rely on Mike when he was there, and I enjoy it. Deformity is amazing. But how did you go about that, and what should tumor surgeons be doing, right? I mean, certainly they should be talking, but the hard thing I think is, what if you don't have a Mike Kelly? Then you're kind of reading the literature, and you're saying, do I need to really know Rousseau well? Do I go down the rabbit hole? How far? Am I going overseas? You know what I mean? Like, how did you manage to do it, and what should people be doing?
Yeah, thank you for that. I take it as I'm probably mediocre at best in both instead of very good in either. But the fact of the matter is, I think the reason that sometimes people go to that world is because the scale of the surgeries are both potentially large. And so, although it's not really a natural duality, some people say, I am a DGen, I am an MIS. They might do MIS tumors, they might do MIS deformity, but they like to do things smaller. I think my career was I did very large things, and so I wasn't scared of corpectomies or en blocs or 3-column osteotomies. And so I lived in that, and I realized, as I always say to the fellows and residents, if you do something bigger to a patient, you gotta actually get it more right. Yeah. So if you do something small, you can, and a lot of us surgeons feel that way. Hey, listen, we're gonna do a little foraminotomy. Maybe down the road you'll need a fusion at that level. But they really haven't burned any bridges. Or I'm gonna do a laminectomy, maybe come back with a fusion. When you do a 3-column and change someone's alignment, take their whole segment out, you have better thought about how it's gonna heal and how it's, and so I think that's why I live in that world now. To learning, all of us are constantly learning, and no one has, it's a constant change. So the second you think you've figured it out, we're learning new things. And I think all of us are frustrated. I will say on behalf of myself, I'm frustrated by my outcomes because not everyone is perfect. So I know every day there's got to be a better way. Yep. And so that way we do that, we do things like this, we communicate each other, we share our cases, we talk, and I think people have to be, and it's not easy, but I think we have to be courageous to show that when we look in the mirror and with our patients, we're not as successful as you are. Not to put you down and to make yourself feel bad and to hurt your mental health, but to say, I owe it to myself and my patients, if I don't understand something, to ask somebody who might be younger and might not have had the same experience and say, what are you doing? And say, you're asking me my thoughts? Yes, I'm asking you because no one knows the answer. And so we keep doing that with each other, and I think it raises all boats.
So Mike Kelly is not at WashU now, but Keith Bridwell is, and his inbox is full of cases from me where I'm like, hey, we just look at this. Do you think we have this right? Do I give her a little time? Is she still leaning forward a little? And I mean, he's got a huge wealth of deformity experience. So yeah, it's huge. It's tremendous. Well, I think that about wraps it up for us. I think if I could summarize and say, spine surgery is deformity surgery. You got to pay attention to what you're doing to patients when you're operating, and be thinking about deformity principles if you're doing spinal oncology, if you're doing DGen or whatever you're doing, trauma. it's got to at least enter your head a little bit. So thank you as usual for joining me.
Thank you.
Thank you.